We're back, and I would like to again welcome Dr. Richard Libman. This is our 10th telethon for stroke and aphasia awareness. Dr. Libman is the Vice Chair of Neurology, Chief Vascular Neurology, Professor of Neurology at the Zucker School of Medicine at Hofstra, Northwell. So hello again, Dr. Libman. It's a pleasure always to have you here. Question about someone that we met who had had a large stroke and aphasia, has come back a long way, can speak slowly but very clearly, but had an episode not long ago where the speech came back completely for a week, and then went back to where they were, just with the problem that they had with the level that she was at. Is this something unusual? Is it common? Do you know why it would happen?
Thank you very much, Ginny. And that is a fantastic question. And I'm going to approach the question kind of indirectly and then a little more directly, but mostly a little indirectly, because it opens up a concept which is kind of involves fluctuations after stroke. And fluctuations after stroke, better, worse, well documented, observed by everyone over and over again. And I'd like to talk about that a little bit and what could cause worsening after improvement, whereas this was dramatic improvement after the initial stroke, and then relapsing back to the previous stroke conditions and stroke deficits. These are incredible questions. And I would like to mention something else, which you didn't mention before I address the issue of changes or fluctuations after stroke. That in a little bit off camera, you had mentioned that the person who had this speech problem also seemed to have very interesting speech pattern, a very interesting pattern that seemed like a foreign accent, as if they were from Eastern Europe. And I just thought you would like to know, and that everyone watching and listening would like to know, that there is actually and was a subject in stroke called the foreign accent syndrome. And that was published in a whole bunch of papers over a number of years, in which people who had strokes, they didn't necessarily develop a language problem, which is called aphasia, where you cannot talk or you cannot produce speech or you cannot understand speech. So that's aphasia. They did not develop slurred speech, and the technical term for that is dysarthria. Just throwing those terms out there. So two different speech problems. Dysarthria, problem with articulation, basically. So you're slurring your words, but your language is normal. You're using all the correct words and you're understanding language correctly. Versus aphasia, which is a language disorder. And the two main types, either you can't produce language, you can't produce speech, or you can't understand language and you can't understand other people's speech. And of course, people can have both problems mixed. Aphasias where they can't produce language normally and they can't generate words or think of the words, and they can't understand. And then there was this class of patient who had a stroke, who developed what sounded to all the world like a foreign accent. They would suddenly start talking with a Swedish accent, like the Swedish chef, or a German accent, or a French accent. And it was this fascinating area. And there were lots of publications, and nobody could figure it out. Nobody could figure out how it happened, why it happened to these people. Then there were some studies that showed, well, it would just turn off just like that. And suddenly their speech was back to normal and the foreign accent just disappeared. And then people started to think, oh, maybe there is a psychological component. And certainly there's a huge amount of stress that comes along with stroke, stress, anxiety, depression, even PTSD, post-traumatic stress disorder. I mean, that's all well documented. It is such a stressful event to have a stroke. And people began to think that maybe this foreign accent is actually developing as a kind of psychological reaction, and that may be a manifestation of severe anxiety or depression. which is not to say it's all in the person's mind. It's not saying anybody's crazy. It's just some manifestation of some other aspect of stroke rather than the physical damage to the brain, rather a psychological reaction. Nobody ever figured it out. And the research in foreign accent syndrome has basically dropped off, and people have moved on to other things. But I've seen it. I have seen it among my own patients. And whatever the cause, I can tell you, I've had patients in the hospital who they might have a mild weakness on one side or mild paralysis, something like that. And they understood language and they could communicate. But for all the world, they were starting to speak to me with a Swedish accent. And they couldn't help it, and it certainly didn't look deliberate or anything like that. And that was the foreign accent syndrome. I have seen it, it's reported. So I just wanted to bring that in. That's an aside, and it doesn't really address the question, which is the really important question of what happens after stroke? Because I'll tell you something, it is incredibly common for people to fluctuate after stroke. And you will see it day in and day out, especially in people who have just had strokes and they're in the hospital. And they have a certain severity of their neurological problems, and maybe they're super paralyzed, maybe they're confused, aphasic, language problem, can't speak. And then you come in the next day and they're doing a little bit better. And an hour later, they're doing a little bit worse. And the family says, yeah, but 3 hours before that, they were much better again. So again, this is a little different from your scenario. I'm just broadening it a little bit. That fluctuations after stroke are incredibly common. Nobody knows why. Is it perhaps slight changes in blood pressure where pressure goes up a little bit and you're managing to kind of push a little more blood up into your brain? Pressure drops a little bit because we do treat blood pressure. Maybe it drops a little bit and now you're just getting a little less blood going to that damaged area of the stroke. And so the deficits, the stroke-related problems are accentuated a little bit. Does the person have an infection? And one of the most common causes of worsening after stroke, where you say, well, I don't understand it. We repeated a CAT scan, an MRI. There's no further damage to the brain. There hasn't been a second stroke. The stroke isn't any larger. There's no explanation from the stroke itself. The brain looks exactly the same. Now they have a urinary tract infection, like a bladder infection. Maybe they have a low-grade temperature. And suddenly, all the stroke-related problems are worse. And you put them on antibiotics, and they get 24 hours of antibiotics, and the urinary infection, the bladder infection gets better, and boom, they're back to where they were 24 hours before that. That is sometimes called, it could be just a fluctuation. Sometimes it can happen even months or years after a stroke. Someone has recovered, and then they come in years later, and it's as if their stroke has recurred. They have an identical presentation if they came in the last time with left-sided weakness and slurred speech. Then they make a recovery, and it's 3 years later, and suddenly they come in again with left-sided weakness and slurred speech. They're back in the hospital, looking just as bad as they did at the time of the stroke. You do a CAT scan, it shows the old stroke, nothing new. You do an MRI, it shows the old stroke, nothing new. You look at them, you can't quite figure it out. And then you realize, oh, they've got a low-grade temperature. And sure, lo and behold, they have an infection. Bladder infections I use as an example, just because they're so common. UTIs, so common. Or they've got COVID, or they have a flu, or they have some other respiratory infection, maybe just a bad cold. But that's not obvious always right from the beginning. You treat them, going back to the example again of just a simple bladder infection, and lo and behold, 24, 48 hours later, all the deficits, all the stroke-related problems disappear just as they were after 3 years or 1 year, whatever it is of stroke recovery. They're back to themselves and they're better. Sometimes that's called a recrudescence. It's a fancy word, but it's just meant to say recrudescence. It's somehow recapitulating or repeating the symptoms that had been there, went away because of the natural recovery process, plasticity of the brain is rewiring, good rehab, etc., and now they're better and suddenly they're worse again, but there's no new stroke. So that's the whole topic. If it happens in the short term, right after a stroke, that's called a fluctuation, better, worse, better, worse. If it happens way after the stroke, and now they're stable and nothing is changing, and let's say they're doing quite well and now they're worse, that's called a recrudescence when there's no evidence of another stroke. What exactly happened to the person you're describing that makes them have problems from their stroke, sort of magically get better, and then magically revert? Other than the scenarios that I've told you, we have no answer. Now, of course, in anyone who worsens after a stroke, anyone who worsens, even whether they just worsen from where they were or whether they've gotten better and then worsen again, you have to make sure they haven't had another stroke, because it's not out of the question. If they have a 95% blockage in their carotid artery and that caused their initial stroke, and they have left-sided weakness and slurred speech, and then 3 days later, their left-sided weakness is somewhat worse and their slurred speech is worse, you'd better make darn sure that they didn't have another stroke because you were dilly-dallying around a little bit too long before looking at that carotid artery and either putting a stent in it or opening it up and doing surgery to clean it out, which is the standard of care. And meanwhile, you've left them and now they've had another stroke. So it's not magical. Maybe they started to improve and then they've had another stroke. Now, it doesn't sound as if that's the case in the person that you're describing to me, but I'm saying, while it may be poorly understood, what is happening that causes maybe dramatic fluctuations, as in this person's case? Stroke, suddenly all better, suddenly back to where they were. Do they have an infection? Did the infection get better? Did they have another stroke that made them worse? And then that gradually resolves. I'm not saying that applies to the person you described, but those are the things we have to think about, because those are the things we can do something about and try to avoid. And whether it's treating an infection or whether it is doing everything you can do to prevent a second stroke, there are things that can be done. So we have to look at what are the practical matters that we can address, even though, okay, sometimes we throw our arms up in the air and say, I actually don't know what happened to you. And I wish I could explain it, but at least I can say, you didn't get worse because you had another stroke. You didn't get worse because you had an infection, or for that matter, maybe not an infection. Maybe some chemical imbalance in the blood. Maybe your blood sugar has gone up sky high because you're diabetic. Maybe we overtreated your diabetes and now your blood sugar is too low. And that's why you're getting worse neurologically. And then we address that, and then you get better. You come back to the way you were. Again, it's not quite the scenario, Ginny, that you described, which is a kind of very dramatic kind of scenario that I must say I'm a little bit at a loss to explain exactly what happened to that person, hoping that she'll do well and that she'll make a gradual recovery again after she kind of reverted to her previous state. And most people after strokes, the vast majority, will get better to some degree. Of course, there's no question. But it's a dramatic and unexplained example of basically what we see day in and day out: fluctuations, recrudescence. Do whatever you can do to help people get better. And sometimes it's as simple as starting someone on an antibiotic for a UTI. And that's basically it.
Okay. I have one other quick question. This has really nothing to do with everything that we've been talking about. But when a person goes into an emergency room under a stroke protocol, and the hospitals they jump very fast now, and they get you into a CAT scan very quickly. We did talk about a while back about what you called wake-up strokes, where you wake up in the morning and you don't know if that stroke was 5 minutes ago or 5 hours ago, and that there, with an MRI, you can see markers in the brain when the stroke happens, and then at like 4 hours, so you know if you have that window for the TPA or the tenecteplase. Yeah. Getting into an MRI machine in a hospital can be really hard. Is there a protocol if someone comes in with that situation that you can like jump the line and get into that MRI machine so that you can see where you are in that time frame?
That's a great question, Ginny. And so the answer is yes. But before I answer and just elaborate a little bit, just to pick up on your initial introduction to this concept, to this question, you said, Well, it's not really related to what we were talking about. It just reminds me that when my grandmother used to bring up a totally new subject out of the blue, she always said, apropos of nothing. Apropos
I
of
do
nothing.
think.
I would like to introduce something new. So that's what it is. And but yeah, no, it is a great question. And yes, the answer is most hospitals don't have emergency access to MRI because the MRI is either not available all the time, the technologists who operate the equipment aren't available necessarily 24/7. The MRI is sometimes used for outpatients, which people are coming just as outpatients, so yeah, and then it's not available. So that is a problem, exactly because of the situation you described, where if we can get an urgent MRI, even if someone woke up with their stroke, and we would always say, well, we don't know when it started, so we have to take the time you were last normal, the time you were last well was when you went to bed. We used to exclude all those patients because they were always beyond 4.5 hours, because almost everyone sleeps more than 4.5 hours. And by the time you get to the hospital, of course, even if you slept 3 hours, it's beyond 4.5 hours. We only have a 4.5 hour window. So everybody who woke up with their stroke used to be excluded. And that's really what you're alluding to. If we can show on an MRI, if you wake up with your stroke, that on one sequence, we can see the stroke, and on another sequence, we don't see the stroke. We see it, we don't see it. If it's that pattern, we know that the stroke has occurred within the past 4.5 hours. It just happens that way. And the technology is incredibly helpful to us. But what if they can't have their MRI? And that's really your question. And so basically, if you want to offer a wake up protocol, is what we call it, wake up protocol, wake up for stroke, and we can treat them, you have to have a protocol worked out in your individual hospital to say, if this patient fits those criteria and they've awakened with their stroke and it's still, they've come in 1 hour after they woke up. So therefore, if it occurred 1 hour before they woke up, we are within that window. We just have to prove it. You make a protocol for your hospital with the administration of the hospital and all the hospital leadership to say that MRI must be available. And you have to have a technologist who can operate it, whatever, starting at 5 o'clock in the morning, where maybe they come in at 8 o'clock in the morning. But now you have to have someone at 5 or 6 a.m. You have to have some whatever the reasonable time is when most people are waking up. Fine. Most people are not coming in after 1 o'clock in the morning. Most people are not. There's a reality. We only have so many resources and so many people to operate the equipment and so many MRIs available. But we have that protocol and that process set up in our hospital, and many others do, so that if at all possible, if someone's in that MRI, you clear that machine. If someone's waiting for it, you have them wait. Of course, Ginny, it's always a judgment call. If someone has a brain tumor and their doctor is afraid they just had bleeding into their brain tumor or something, something that's going to require some urgent management, and only that MRI can solve that problem, obviously, we're not going to kick someone out. But most of the time, it's people waiting for their elective MRI because they've been waiting a week or a few days or whatever it is. Even an outpatient, okay, you don't want to make an outpatient wait, but if they have to wait an extra 20 minutes and say, okay, we have an emergency because we can treat, we have that protocol. And that's our neuroradiologists and the hospital leadership, administrators, and many of our hospitals do in the Northwell system, because we have implemented the wake up protocol, and we want to be able to treat those patients. So is it available everywhere? The answer is no. You have to have the support of the hospital leadership, and you have to make a good argument for it, and it has to be feasible. And not all hospitals even have MRIs even today. And some hospitals have their MRIs down the street rather than in the building, and then it becomes a little less practical. So everybody does what they're capable of doing. I don't want to insult any individual facility. Everybody's doing their best, and every hospital is doing their best. But most certified stroke centers, primary stroke centers, as in you can give TPA and you can give tenecteplase, or comprehensive stroke centers, you can do the aggressive management with catheters, endovascular thrombectomy, meaning mechanical clot retrieval with a catheter, pulling that clot out. All these hospitals have the facilities, resources, and approval and organization to do wake up stroke protocols, get that patient to an MRI quickly, even when they woke up with their stroke. We don't know exactly when the stroke started, but the MRI can clarify that for us, and then we can treat them.
It's very reassuring, and I'm glad I live in an area where there are hospitals that do have that protocol. Thank you so much, Dr. Libman. We really, really appreciate your time. We know how busy you are, and I'll see you soon for my annual checkup. And I look forward to that and getting good news as you always give me. Thank you again for being on our 10th annual Language of Love Stroke Telethon. Take care and be well.
And you too. And always a pleasure, Ginny, to be here with all of you and to see you individually. Always a pleasure.
Thank you.
All the best.